Kia ora koutou, and welcome to tonight's Awe and Taskforce Kiwi session. Whether you're joining us from New Zealand or Australia or a little bit further afield, it's really great to have you guys with us. We have a special kind of speaker session that's being put on by the Australian Women in Emergencies Network, or AWE. My name is Amy Markello. I'm part of the New Zealand chapter, and I'm a committee member with AWE, and I'm just going to be kicking us off really quickly before I introduce our fabulous guest speakers, Malin and Campbell. And just before we go any further, I wanted to open us with a karakia. You're welcome to join along with yourselves on mute or off if you'd like. But whakataka tehu ki te uru, whakataka tehu ki te tonga, kia mā kina kina ki uta, kia mā tara tara ki tai, e he ake ana te atakura, he tio, he huka, he ho hu, ti he mori. So get ready for the westerly and be prepared for the southerly. It will be icy cold inland and icy cold on the shore. May the dawn rise red-tipped on ice, on snow, and on frost. So just a little bit of something to kind of take us away from what we have been doing and focus us in on this session tonight. So with that said, I would love to introduce Malin, who is our first of kind of two amazing guest speakers from Taskforce Kiwi and a variety of other activities. So Malin, if you wanted to take it away.
Okay, kia ora koutou katoa. It's a great honor and pleasure to be here with you tonight. Thank you so much for completing the survey. My reason for doing that is to find out a little bit more about the audience, because it's quite random to speak to a screen rather than to people in a room. But now I feel I know a little bit more about you. And the other reason for doing it, I wasn't sure whether anybody would be interested in my bit of this presentation or whether we should go straight to Campbell's. But it's very reassuring that some people actually want to hear my bit. So next slide, please. Okay, I think I should just very briefly start to explain how I ended up as the medical director for Taskforce Kiwi. So my name is Malin. If you think of the big fish with a long nose, Malin, just no R, that's how my name is said, Malin. My surname is Zachau. Originally in the 1600s, it was Zachau, but we have anglicized it to Zachau. So I grew up in Sweden and moved to the UK when I was 15. I worked as a doctor for 25 years in the UK. I started off as a solo GP in East London, and I volunteered as an immediate response doctor with London Ambulance. So I had a vehicle with a green light on top and sirens and lots of fancy gear in the back. So my scope of practice was what's similar to Kiwi intensive care paramedic now. And the reason for that was at that time, the ambulance crews in London, they were at a scope of EMT. So I deployed to things like motor vehicle crashes, industrial incidents, transport incidents, civil unrest, and terrorist incidents. Now, because I am short and small, I was often sent into the confined space rescues and to the people who were trapped, either in vehicles or building. So, yeah, I worked very closely with ambulance, police and fire. And I suppose that's why I feel a little bit like a uniformed services veteran. Somebody need, yes, thank you. So after my time in London, I moved to the Midlands, where I worked in an emergency department. It was called staff grade. So basically I was a consultant, but just not paid as much. And then I settled down to GP work which was, I looked after a very large, very complex care nursing home, and also did a lot of palliative care. And then in 2010, everything changed because I became paralyzed. Now, it wasn't a spinal cord injury. It took us a long time to figure out what it was. So I live with a rare condition. It's a genetic skeletal muscle ion channelopathy, and it's called hypokalemic periodic paralysis. And what it does, it means that I paralyze without much notice. Now, that's not clinically safe to work as a doctor, and unfortunately, I've not been able to work since 2010. In 2012, we moved to Christchurch. My husband is Australian and has been involved in the Christchurch rebuild. In 2013, I started to volunteer with a Christchurch-based outdoor pre-hospital emergency care training provider, so outdoor FEC. And the plan was that I was going to be a tutor, but I promptly paralyzed more than once, which was very embarrassing. So instead, I became their volunteer medical advisor, curriculum advisor. So what that meant is that I attended all the FEC courses and sat in a corner drinking tea with mountain guides. And I'll come on to that in a bit. So then that evolved to me doing some research on New Zealand avalanche fatalities and New Zealand accidental hypothermia fatalities. I ran the New Zealand Society for Mountain Medicine for a few years, and then I handed that on to a younger person who you will meet later this evening. I am now the Vice President of the International Society for Mountain Medicine. I am the work group leader for the Mountain Emergency Medicine for mountainsafety.info. Now, that's not the New Zealand Mountain Safety Council. It's a mostly European organisation led by Manuel Genswein, who is very famous in avalanche circles. And they have produced the Avalife. We're now working on crevasse rescue. I'm also the civilian representative of Aotearoa Tactical Medicine New Zealand. So yeah, because I can't work, I volunteer. And then in January 2024, I joined Taskforce Kiwi. Campbell and I worked at the same time, joined at the same time. Okay, you don't need to know anything else about me. This is the rest of the evening's program. So please may I have the next slide? Okay, so being the medical director for Taskforce Kiwi is quite a wide portfolio. And because obviously we wish to look after our volunteers before, during, and after deployments. But we're not going to talk about that tonight. And we're only going to talk about the first aid aspect. However, the Taskforce Kiwi Mental Health Strategic Advisory Group is doing great work. And I wish to give a very warm thank you to Matt Jensen, who leads that group. So thank you very much indeed, Matt. Great. Next slide, please. Okay. Now, both Campbell and myself will be mentioning austere care and in situ responders. So I thought it's only fair that I define how we use those words. So austere care is basically medical care with limitations of human resources, equipment, training, and there may be limitations to infrastructure, transport and communications. So we'll come on to some of that a bit later. Now, in situ responders, they can also be called companion rescuers. That's the term we use in avalanche rescue. Now, and what we would be dealing with is incident within an incident. So if a deployed team goes to disaster recovery and then something happens to one of their volunteers, that's an incident within an incident. Now, that means the first aiders do not receive any warning of the event. They don't get a phone call or an alert saying, could you please respond to an incident down the road, because it happens where they are. The other thing is that the first aider will almost certainly be part of the incident. They will have seen it happen, and they may even be physically and emotionally impaired themselves. And particularly because they will know the person. So it's a bit like when a paramedic or firefighter unwittingly responds to one of their family or friends. So I just want us to keep that in mind for the rest of the evening. Next slide, please. Okay, so I'm only going to touch on what Taskforce Kiwi does as far as medical stuff. So Taskforce Kiwi is an expeditionary organization. We travel to where disasters have happened, and we provide practical direct assistance, so boots on the ground. So after a flood, it might be shifting silt. It might be using chainsaws to remove fallen trees, and it might be putting new fences in. So it's boots on the ground. Taskforce Kiwi has a very important dual purpose, and that is veteran purpose. So whether it's Defence Force veterans or Uniformed Services veterans, to have an opportunity to serve in a purposeful way, to serve their community, but also to do that in with camaraderie, in a group of like-minded people who have similar backgrounds. It's very good for mental health. Now, our medical scope. So Taskforce Kiwi is not a medical organization. We are not an emergency medical team. We are not a medical assistance team. We are a disaster recovery organization. However, within humanitarian principles, it is essential that expeditionary teams must not become burdens on the disaster-affected communities. And that is where our first aid response that Campbell will talk about comes in. Now, limited resources. So Taskforce Kiwi now has 807 volunteers, which is fantastic. However, only 1% of those are currently registered paramedics, and only 2% of those are currently registered nurses. Now, as far as I know, and I could be wrong, as far as fully registered, clinically active medical doctors, I believe we only have one. And that's our lovely Dr. Dick Ongley here in Christchurch. And we are absolutely delighted that he's come on board with the prescribing and the medical oversight. So thank you very much. Now, Taskforce Kiwi also has limited financial resources. We do not receive any government funding. We get grants and donations, but you know, it's not easy, which means we can't buy all the equipment we want. But as Campbell will mention later, we did manage to get a lottery grant that we are extremely grateful for and managed to buy some stuff. Okay, and great. So what? Why should any of this be of any interest to you? Well, I have personally noticed that the in situ responders, if they have appropriate training, appropriate equipment, and appropriate support, they get not only good patient outcomes, but they also get good rescuer outcomes. If you send people out to deal with incidents within an incident without the training equipment and the support, they can suffer a lot afterwards if there's a critical incident. PTSD is very common, unfortunately, in the mountain guiding community. Okay, so I was looking for something that would help me work out what is the appropriate level of first aid training for the various deployment situations that Taskforce Kiwi deploys to. So I assumed there would be a spreadsheet or an app or a tool of some kind where I could just put in that and come out with a result. I couldn't find anything. Now, for planners and managers, there is the duty of care. There is a duty to appropriately look after the people deploying into disaster recovery. Whether they are employed or volunteers, there is a duty of care. So what I was hoping to find is something that helps with team selection, team composition. So to objectively determine the appropriate capabilities, I ended up coding an app. Next, please. Okay, so everything has to have a catchy acronym. So FACET, First Aid Complexity Engagement Tool. It's been developed to provide an objective assessment of the first aid skills required for the deployment. And FACET is suitable for disaster relief organizations that have limited medical resources. Now, we don't have enough paramedics, nurses, or doctors to send one every deployment. So we have to use our resources wisely. Next slide, please. Okay. I don't expect you to read and understand this slide fully right now, but it is a good looking slide. My last slide is the QR code to my website where you can scrutinize that and lots of other things in detail if you're interested, and I hope you are. So FACET, it's a first pass. It's not a be and an end all. It's integrated into the decision making. Now, it uses unmitigated risk. And then when the risk has been analyzed, it can decide what mitigations need to happen. So it can start discussions about that. Now, if Taskforce Kiwi deploys with a partnering agency, it's a good way of discussing with them. So if they are responsible for providing the first aid during the deployment, this is a good way to see whether they have the appropriate capability or not. Okay, next slide, please. So within Taskforce Kiwi, we have 4 levels of competencies. We have basic first aid trained volunteers. Now, those are volunteers who have done NZQA 6400, 6401, and 6402. Then we have the disaster first aid trained. So they have done the basic first aid training, that's a prerequisite. And then they have undertaken the course that Campbell will tell you about. The next step up is advanced first train, so that's EMT level or Defence Force Medic, but obviously with standard operating procedures and standing orders. Again, Campbell will go through that. And then registered healthcare professionals. There are 7 scoring factors that we put into the FACET. Next slide, please. Okay, so you can see what the different scoring factors are there, and I'm very proud of this logo. You don't have to read them or understand them now. Next slide, please. Okay, So this is a hypothetical simulation. It is similar to a deployment that Taskforce Kiwi has undertaken, but it is not identical. Again, you don't have to read those things because we'll go on to the app next. Next slide, please. Okay, so now Amy is going to make this unlisted YouTube video play. It only goes for 5 minutes, and then I have one more slide, and then I'm done.
Can you all see that and here?
I can see your yellow logo. Yes.
The full instructions are on my website. Now that is important because some of the input factors in the pinwheels are abbreviated. So it's important to have looked through that first so that it's very clear what input factor to choose. The second blue link is to Taskforce Kiwi website. There's also an acknowledgement of my friend Alexandra. He gave me the idea to code this. At the bottom, there is an I understand proceed to calculator. Now, because I've already clicked that, it's not highlighted and we can go straight through. So in our simulation, the deployment is going to be taking place immediately after, in the immediate aftermath of the disaster. Now, it is an international, non-urban or remote environment. Now, the other ones are international urban, New Zealand remote, New Zealand rural, urban easily, and the bottom one is major infrastructure collapse. So that would be after a alpine fault sort of earthquake. So anyway, there we go, non-urban or remote. The volunteers are going to be there for up to 2 weeks. Now, they're going to be doing skilled works, prior training required. So that is what we choose for chainsaw operations. The other ones we have is working in public spaces, working at height, working in environmentally challenging, working in confined spaces. So anyway, we are skilled works prior training. So because it's chainsaw work, it's catastrophic, potentially life-threatening. On this particular island, there's only there's actually no emergency services. We've got the various different levels, as you can see. And this is where you need to have read the full instructions on the website so that you know what each sentence says. I'll hope to get that fixed when it's become readily commercially available. Okay, so going back to our simulation, emergency service response time, because there is no emergency services on the island, it would require evacuation to the main island. That is by boat, it's weather dependent, and it could be over 12 hours. So our final score is 48, and the required capability is a registered healthcare professional. Now, you could say that we could have guessed this because of the situation, and I agree. The same is the case for the very urban, low-level, with good emergency services with short response time. Those are also easy to guess. It's the in-between ones where this can be really useful. The other useful thing is that you can export it to PDF, and then you can have a record of how the decisions were made. The fourth page has the link there to the various capabilities. So it's got, for Taskforce Kiwi, we've got basic first aid, we've got our disaster first aid, and we've got advanced disaster first aid. So that is at EMT level. And you can, if you're interested, you can look through all the different things. And Campbell will can go through some of that later on in the webinar. Oh, sorry, I shouldn't do that because it'll make you feel quite seasick. Thank you very much. Bye.
Okay. Thank you very much indeed for that, Amy. It cut off the very first bit, but that's of no consequence. So please could I have my final slide? Okay. So now I've told you what Taskforce Kiwi medical capabilities. We've said, so what? And now we would say, now what? So the fact is that this tool is made freely available to small, low resource disaster relief organization. It's open source. It's on GitHub. It's available as a spreadsheet or an app that it has to go through Expo Snack, but that's easy. It says on my website how to do that. And I would happily help out with customizing it to other organizations' requirements. And that is the QR code to my personal website. And thank you very much for your patience. And I will now hand over to Campbell. Thank you.
Hello. Thank you, Malin. That was very good. So my name's Campbell. This is briefly about me. So by day, I'm a frontline paramedic in Christchurch, and I have my finger in many various pies, being one of them Taskforce Kiwi, for which I help Malin and Dr. Ongley and a few other people, Katie Seabrook, on our medical working group. I'm also the president for Outdoor Medicine New Zealand, formerly the New Zealand Society for Mountain Medicine. And if you're interested in that, just type in New Zealand Society for Mountain Medicine, NZSFMM, into Google, and you can see some of the things we're doing. We've run some webinars as well. I've instructed various courses in various environments and contexts, from clients going to Antarctica to junior doctors, other paramedics and volunteers, and do some mentoring on the ambulance as well. And I'm a serial volunteer, one of my favorite phrases. So here I am. The photo of me there is just me at the end of a contract where I provided some private paramedic services to a sports camp in South Auckland, where some under-resourced schools get a chance to go do various sports they wouldn't normally have the opportunity for. And it's a good opportunity for me to give back a little bit and provide good quality healthcare to people that may not normally have access to that, and also help kind of mitigate the risk of people playing sports. And I think mitigating risk is all kind of what we're talking about this whole webinar and all of the work we do for Taskforce Kiwi. So next slide will be good. So Malin and I came into Taskforce Kiwi, and we thought, oh, all right, this is cool what we're doing. I like this. It's a model we'd seen or heard of overseas already, and we're kind of thinking, what's happening from a first aid side of things here? If people are going into potentially a remote area or somewhere that may not have a operational ambulance service, for example, what happens if someone gets ill or injured? So anyway, we set out to fix this problem. And what we came about doing was we thought, right, well, we can't get, an EMT or nurse or paramedic into every deployment. The numbers just aren't there. However, what we can do is we can implement a similar system to what is already used by many, many ambulance services around the world, and as well Defence Force and a few other similar organisations doing similar things. So we can train our people to be the eyes and ears of someone on the phone. So we can train people to provide immediate care, stop the bleeding, comfort someone, give them a blanket, get them to take some vital signs and do a basic assessment, and then ring somebody like myself or a doctor or another clinician and say, look, this is what I've got, this is what I've done, here's what I think should happen. Have you got any thoughts? And that is how we can bring the nuance of diagnosis, the experience, the gestalt of professional medical care to a remote area when there's not actually a clinician on scene. So how we did that, we developed disaster first aid course. And yeah, the idea was to train people on the hard skills. How do I actually take a blood pressure? How do I take someone's temperature in a way that we know is accurate? How do we clean a wound such that we're solidly preventing infection and dressing it well, as to reduce the chance of needing to evacuate someone. And the idea of this, Malin mentioned briefly, was to reduce burden. And I thought, our teams need to be deploying ethically. If we send a team of 10 people to a remote Pacific island and 3 of them get traveler's diarrhea and end up spending a few days in hospital using IV fluids and medicines and a bed each, we're actually placing a burden on that already disaster affected area. So if we can mitigate that as much as possible, it means we're deploying our people ethically, as well as having in line with the health and safety aspect of deploying people overseas and within New Zealand. So a few things we did. We developed this course. It had to be, we decided on a 1-day course with a prerequisite of people had to have some first aid experience, preferably a recent basic first aid course. And that was so that we didn't have to be teaching them on this course, things like CPR and choking and basic bleeding control. We wanted our course to be really hard hitting for the skills people need. Bear in mind, the things that we're teaching people would normally be taught on a course like wilderness first responder or pre-hospital emergency care. So they'd normally be a 3, 5, or 7-day course. And I thought anything longer than a day with some pre-reading, that would create a barrier to people coming onto this course and taking part. So a 1-day course with people doing a first aid course beforehand so just so they have a baseline level of understanding of first aid, that kind of fitted the bill quite well. And you can see our picture here. This is some of our disaster first aid medics. They're assessing a wound in some pig skin that has been warmed to body temperature, and they're closing it, cleaning it, closing it with stereo strips, and treating, learning how to dress it for multiple days and do dressing changes and documents and things like that. So that is one of the things we do on the course, and it's quite a high impact training that we do. Next slide. Here is the actual look of the course, and this is preceded by some pre-reading, which is the pre-reading is mostly about some concepts, some of the paperwork things, and some of the medicines. But broadly, we refresh people on doing a primary survey. So the doctor's ABCs, a little bit of a head to toe for bleeding. And this also serves to act as a bit of an icebreaker as well, and just see where people are at on the course and get people warmed up. We then teach people how to take vital signs. So they learn how to take a pulse rate, a respiratory rate, to measure the saturation percentage of oxygen, a non-invasive blood pressure, urine output, and more level of consciousness, for example, and to how to document that and chart it over hours or days on end, kind of like what a nurse would do in a hospital. And these are new techniques to people that may have some firefighting or even ambulance experience. Unless you have nursing experience, you're not used to charting vital signs over, say, 2 days, how often they should be taken, and watching for trends. Noting that here we're mostly teaching people how to do the hard skill, and then the interpretation of that vital sign is down to whoever's on the phone with the medic at the time. So it's kind of easy in that regard, because teaching someone the nuance of a pulse rate is slowly increasing over a day would take more than the time we can devote to this. Otherwise, we do some major bleeding work, and that's because we do a lot of chainsaw work in Taskforce Kiwi with debris clearance, and as well the use of arterial tourniquets, while very important, is not routinely taught on first aid courses in New Zealand. Commentary on them has recently been introduced to the NSCORE, our first aid guidelines, but yeah, we found it was an important thing to add for anyone working in these environments. Splinting as well, to help people use non-pharmacological pain relief methods. So if we can manage pain in a way that's not using medicines, I think that's always a positive thing, and it reduces the amount of medicines we need to be giving people. Heat illness, and this is actually an optional part of the course. Routinely, we've been teaching hot environment illness, and whether that's exertional hypothermia, someone's been working too hard, they've got too high temperature to the point where their brain is not functioning so well, or some tropical illnesses, envenomation from snakes, which is something that was new to me, and will be to most New Zealanders if they're deploying to, say, Queensland or Vanuatu or Papua New Guinea. That also changes regionally. This may change if we were running a disaster first aid course prior to someone going on a deployment or some pre-deployment training. I would tailor what's on this course for the environment they're going to. Otherwise, the minor wounds practical, so that's that the lacerations and the skin tears and pig skin, and they get to practice some things like jet lavage or using pressure to clean wounds, which has been evidence-based to reduce infection and reduce microbial burden, which is quite positive. And we finish with a long form scenario, which I'll talk a bit more about later on. But that really helps us use many of these concepts that we've discussed through the day. And yeah, it's a patient that has multiple injuries or pathologies and illnesses going on. It also helps for us to, on the phone as the telehealth clinician, to practice doing the consults on the other end. Next slide. So here's the long form scenario. So we have a patient. I'll spoil this for anyone that's about to do this course. The scenario will probably change, but we have a patient who has been walking, say they've been doing some debris clearance, they fall or trip on a log, they've dislocated their kneecap, and clearly they're in a lot of pain. Whoever the medic is will come and assess. They'll rule out bleeding. They'll say, oh yes, you've got a deformity in your knee, it's very sore, we need to get you some pain relief. So they look for some pain relief, paracetamol, ibuprofen, and inhaled green whistle methoxyflurane inhaler is a good start, for which they need permission for that through the on-call clinician. And then they'll take sets of vital signs and they'll go, oh, this patient's actually got a fever. What's going on here? And so we have to work out, is it exertional heat illness that's making this person tired and that's why they've fallen? Or have they actually got an infection brewing, like a urinary tract infection or a gastro bug? So certainly there's a bit of complexity here. They might have a graze on their elbow as well that needs to be irrigated and dressed. So that's the long form scenario. And yeah, it goes over about 2 hours with a wee break in the middle for some telehealth consult. And with the telehealth, people learn to do a script, just so we're not missing information. And we use already established templates and communication tools for that. Next slide. So bearing in mind, all of this is kind of new and still in its infancy. In the recent Marlborough floods, there have been a couple of real-life teleconsults done, one by myself and one by Dr. Dicko. As a whole, they were successful. Patients had a good outcome, they were cared for, and I think they were all happy to have that service in place. I won't talk about them in specific due to privacy reasons, but I think it's evidencing that what we're doing is good. There's a wee news article there about some of the work Taskforce Kiwi did running some evacuation centres when the weather packed in during our response, which exemplifies why we kind of need to be very careful about our health and safety and making sure that we've got the equipment there, because it's always unpredictable when disaster strikes. Next. Medical oversight's important part of what we're doing. So I wish it were as easy as kind of how I've described it. Let's put some medicines in a kit, and even if the medic doesn't know how to use them independently, they can give us a phone call and we can say, right, give medicine 3 out of box number 2. But it is complicated doing it safely and in line with various registering bodies guidelines. And we remain accountable at all times. So we need to ensure that we're doing things ethically from the prescribing end, as well as responding ethically to these disasters. But we feel that it's a very good way for us to get the level of care at the scene that these people need. And here's one of our volunteers, which is drawing up an antibiotic for injectable in a training scenario. Next slide. After our courses, we've informally surveyed participants, and we found a 28% increase in perceived confidence. So people were asked to rate how they felt doing a skill before and then after the course. And as a whole, most people's confidence improved, and we were very happy to see that our training was working and people felt empowered to do what they needed to do. Of note, there were a couple instances of people that didn't feel as confident in performing a skill or being in a situation or managing a situation that they may have felt before the course. But I view this positively, because I feel like that reduced confidence has come from people knowing more about it and therefore understanding the importance and the depth of the decisions made. And that reassures me that they will do a telehealth consult and get a clinician on the phone, because something that may seem as simple as they've got heat stroke, let's cool them down, may actually be a life-threatening emergency or an infection rather than a heat stroke happening instead. So I think that's just a fascinating point. And here you can see one of our operators chainsawing on their belt. If you can see, they've got a stop the bleed kit, which is part of the equipment that we've been issuing people. It's got a tourniquet, bleeding control bandage, hemostatic agent to stop bleeding, gloves, shears, and some packing gauze. Yeah. Next slide. The kits, everyone gets excited about gear. So from our experience, as a working group and from previous experience on deployments, we had to pick what was the right gear for this. Starting with the actual case, we wanted something that was waterproof. We've done some operations where gear has come back moldy, or we've been operating on boats and we wanted things to float if they were going to fall off, and we wanted things to be carry-on approved. In fact, I've flown with these kits as carry-on, and I think that's just important so that we can be accountable and flexible with when and where we're going. If we're starting in a small plane and then ending up on, or starting on a large plane and then ending up on a much smaller plane, going between small Pacific islands, for example. And we've also got standardized pouch colors. And this is standardized across all the kits in Taskforce Kiwi, and also standardized across ambulance services in New Zealand and to an extent Australia. So for both of the frontline ambulance services in New Zealand, the yellow pouch, for example, is medicines. The blue pouch is kind of airway and breathing things or miscellaneous. The red pouch is trauma gear, tourniquets and the like. So these kits are very good. And what it also means is kind of what I mentioned before. If I'm on the phone to someone, I can say, right, open the blue pouch and get the XYZ. It's really easy in a high stress environment. Yeah. Next slide. Here's the actual contents of the kits, and this is something that we had graphic designed. So again, color coded. It's the same layout as the inside of the kits, and that actual graphic is on the inside of the lid. So as soon as you open it, you can see that graphic, and you can go, right, red, major bleed, I need that kit. Cool, come back. Some interesting points that we've got under the medicines is where I put a lot of thought into this. I wanted mostly medicines that people would be familiar with, and paracetamol, ibuprofen, having an antihistamine as well, and picking which one, something that worked fast and was potent rather than something that worked over a long period of time. Just if we're treating an acute allergy as opposed to, say, hay fever, for example. Otherwise, having medicine to reduce nausea and vomiting. If we are getting people who have reduced appetite from infection or have an infection and are vomiting, and we want to rehydrate them, as well as that, having oral rehydration sachets. And I'm a big proponent for this. Having some sugar and some salt and water will help it absorb and provide very basic nutrition, much better than just normal water alone, particularly if someone's not eating. We're looking to carry an antibiotic, which is still in development, but we're kind of thinking something for skin, so either that's wound coverage or for nasty bug bites. There may be other uses that come up as well, and some other emergency medicines. We also carry a dental pack, and when I was looking at some of the literature around expedition medicine complaints or things people are presenting with, dental actually features quite highly on these. And if you think about it, if we have someone who is somewhere far away from a dentist, but they have a filling come out, or they get whacked in the face and a tooth becomes loose or even entirely dislodges, you can get a lot of pain from that, and it can also be long-term consequences from these injuries. So having some temporary dental filling, clove oil as well, is a really good pain relief for dental injuries. And just having things like a dental mirror so that you can kind of have a good look and see what's going on. Noting that you'd also use items from the rest of the kit. They kind of complement each other well, because space and weight is very important here. Otherwise, wound gear, and having a wee foldable stretcher too, as well as personal protective equipment. I'll just answer some of these questions which are in the chat. So somebody asked about having AEDs, automated external defibrillators, in the kit. And this is something that as a group we thought about a lot, and I took some advice from the Defence Force. We thought, depending where we are, if we're deploying somewhere where the ambulance service is intact, we're likely to have a pretty quick response for a cardiac arrest or when an AED is needed. And as well as that, we can have in our action plans where local defibrillators are. But if we're somewhere like a Pacific Island and emergency extrication is going to be via aeroplane and take probably days on end to do, we thought if we resuscitate someone and shock them into a normal rhythm with the AED, we just can't provide the essentially ICU level of care that that patient needs. You know, many medicines to maintain their blood pressure, IV fluids, monitoring blood tests, high flow oxygen, things like that. So the short answer is no, we don't have any AEDs. It's not to say we won't in the future, but our opinion is in a really rural and remote area, there's probably not that much of a role for defibrillators, and our volunteers need to understand that if their heart stops and they're that far away from help, that's kind of game over for them, and we have to be accepting of that risk. Someone says, how do you connect with the local medical services or emergency medical teams? Prior to each deployment, we do a evaluation of the area. So we look at where are the nearest hospitals, urgent cares, the ambulance services and their phone numbers, if the ambulance service is even intact. So that is given to the teams on a sheet. And that can vary, so it's deployment specific regarding to contacting EMS. Can we please get a forward-looking plan for task force aid courses around the country? Short answer, Rob, there's no disaster first aid courses that are currently booked in, but that is likely to change very soon. So that's my answer to that question. Otherwise, that is really it from me. So I'm very happy to take questions, and I'm sure Malin is too. But yeah, that is the work we've been doing, and I think we're very proud of it. So I'd like to say thank you for listening, and yeah, we're happy to take questions.
Okay. Thank you very much indeed for that, Campbell. I can see two questions. One from a friend of mine in the UK, Chrissy, who is a burns nurse, and I'm going to message her privately about our burns dressings. And there was a question about whether our volunteers are police vetted, and yes, they are. Everyone has to have their police check as before they come on board as Taskforce Kiwi volunteers. Yeah. Were there some other questions as well that we haven't answered?
Brian's got a question here. He says, thank you for the presentation. Based on previous deployments, what are typical issues that need treatment? We've been quite lucky to have not had many incidents that have needed treatment. However, a few off the top of my head, one person that had essentially gastro, so diarrhea and vomiting and dehydration resultant from that. There's been some mental health crises. There's been people that would normally have a medicine administered by a health professional, but that wasn't available. And otherwise, just a few minor wounds needing plasters and things like that. But I certainly see the potential for infections in dirty environments and also nasty large wounds from use of hand tools, for example.
So thank you for that, Campbell. I'm just going to jump in and say that we are At this stage, we are planning to only look after our own team members, and our plan is to deploy during the recovery phase of disasters. However, disasters are dynamic, and when there is an incident within an incident and the local community are affected, there was an occasion where we looked after patients of the local community. Now, that was with telehealth support, and that was the person who needed a medication that they didn't have. But, you know, we're very conscious of only operating within our scope, but we also need to be agile and flexible. Now, there's a question here from Susan. What are the process by which we are deployed? Okay, so Taskforce Kiwi is not, we're not disaster tourists. We don't just, jump in somewhere where we think we should be. We always wait to be invited by appropriate authorities. And it tends to be in the recovery phase rather than in the response phase at this stage.
I will add, if anyone's interested in further reading about this, prolongedfieldcare.org is a very good resource. It's kind of from a military perspective, however, has got a lot of the topics that we've discussed today, and a lot of the work that I've done for Taskforce Kiwi is based off prolongedfieldcare.org. And they've got a clinical practice guideline as well, which has got specific treatment recommendations, which is really good. And in New Zealand and Australia, a company called Ragged Edge Pacific, which I do some instructing for, runs a austere emergency care course, which is a 4-day course that's fantastic. It does cost a pretty penny, but it's a great experience for anyone involved. And that's it from me.
And I will just finish with that Katie, who is our national training manager, will be putting together a calendar of training courses for 2026. And yes, we're hoping to give plenty of notice so that people who are interested are available.
I think that takes us to right at about 9 o'clock. So it's the end of our session. But if you have any further questions for either of the presenters or for Awe Network, you're welcome to send them through in the chat or by email, and I'll make sure that they get answered. But just wanted to thank you all for coming along tonight. And yeah, I think if that's it from both of you guys, I will close this with karakia and let everyone continue on with their evening. Okay. Kia whakaria te tapu, ki wai te ai te ara. Ki tūru ki whakataha ai, ki tūru ki whakataha ai, homie huie tāke. Restrictions are moved aside so the pathway is clear to return to everyday activities. As everyone's noted, really awesome presentation. Thank you guys so much for giving up your time to come here tonight. Noting Richard and Katie, I saw you guys on the line as well. So thank you guys for joining and for supporting this really awesome effort. So,
Thank you very much. Thank you. Good night.